Hi there, it's Chris Trimble here, coming at you from your favorite place and mine. That is, of course, Dartmouth College. And I'm so pleased that you joined me here today and pleased to be a part of this ongoing webinar series, Dartmouth Tuck Free Lunchtime Webinar Series. I think it's a fantastic way to keep in touch with alumni, and I thank you for spending the hour here with us today. You know, I've been here at Tuck since 2000, and over that time my field has been innovation within established organizations. And so I've done most of my teaching and research here at Tuck. But a few years ago I received just a delicious cross-campus invitation to focus my efforts on a particular industry, perhaps the most important industry in the country, both in economic terms and human terms, yet it may also be the most troubled industry. I'm talking, of course, about healthcare. Studying innovation in healthcare delivery has been energizing for me. And I must say that a lot of that energy comes from many world-class experts in healthcare that we have here at Dartmouth. They've inspired me, and I'm very grateful for their inspiration, their insight and support. They've come from the medical school, they've come from our Health Policy Institute, and of course from here at Tuck. You know, when talking about healthcare, it's very easy to feel morose. But there is good news, and that good news comes in the form of a literal treasure trove of untapped opportunities. There's so much opportunity for innovation in healthcare delivery, in fact, that I don't think the low-hanging fruit metaphor is descriptive enough. It's more like we have a giant field full of enormous watermelons just sitting on the ground. I'm here today to talk about how to capitalize on those opportunities. Before we go any further, though, just a couple of notes about the technology we're using. First of all, we have just one way, audio and video. That means you can see me and you can hear me, but I can neither see nor hear you. That doesn't mean we can't be interactive, and in fact we can. There is a chat window that you should have in front of you. Keep in mind that anything you type into the chat window will be visible to everybody we have online today, about 200 alumni. That said, I'd love for you to use the chat window however you like, to share a remark or a reaction to something I've just said, perhaps to share a link to something online on the internet that you'd like others to be aware of. But most importantly, you'll use the chat window to ask questions. And you can do that at any time over the course of the presentation. On that note, I'd like to introduce Addie Ferber, who's with me here today. Addie is the Associate Director of Academic Affairs in Dartmouth's Masters in Healthcare Delivery Science program. And in addition to her leadership role, she's a scholar. She's studied and written about what goes right and what can go wrong when patients and clinicians communicate with each other. She's also been very supportive of me and worked closely with me in the class that I teach in that master's program. And so I'm very grateful that she was able to make time available today to work with us. Her role today will be to monitor the chat box and to moderate the Q&A. What we've decided to do is to tackle any quick clarifying questions immediately as they come up at the end of each section in the presentation. We'll save the meatier questions for the very end during the Q&A session. But again, you can pose a question anytime you want. While Addie is not on camera, she is on voice. Addie, why don't you say hello?
Hello to everyone participating virtually. It's good to have this opportunity to work with Chris and to share his learning about innovation in healthcare delivery with you. I'm looking forward to seeing your interesting questions. Thank you.
Thank you, Addie. Let's move on then with our 5-part agenda today. Part 1 is called The Cheap and Curative Pill. Part 2, A Simple Innovation Story. Part 3, The Prescription, and yes, that is the prescription for fixing healthcare. Part 4, The Climb to the Summit. Part 5, Bright and Shiny New Objects. We'll then have a lengthy Q&A session, and when that's complete, just ahead of the top of the hour, I'll have a very brief wrap-up and sign-off. Onward with part 1. The cheap and curative pill. Here I'll start with a very brief personal story. I'm very happy and very fortunate to be able to report that I've lived a healthy life. And indeed, I've had but one acute episode, and it was way back in high school. My appendix ruptured, and the ensuing abdominal infections were severe enough that I remained in the hospital for more than 2 weeks. Not a big deal in the context of all that goes on in the nation's hospitals every single day. I have, though it was a long time ago, a few very vivid recollections of that time. For example, I can remember losing a whole lot of weight and looking incredibly skinny. I can also remember the surgeon. I can remember exactly what he looked like, and I can still remember one particular remark that he made to me. He said to me, "You know, Chris, not that long ago, before we had these industrial strength antibiotics you've been on, people died from this." Now, as you can imagine, as a young 16-year-old boy, that got my attention. But at so young an age, there's really no way I could share the surgeon's perspective on the velocity of medical advance. He'd seen penicillin in the 1940s, the vaccine for polio in the 1950s. The 1960s brought us the first major organ transplants. The 1970s, CT and MR imaging. The 1980s, stents. In the 1990s, we turned the tide against AIDS in the United States. And in the most recent decade, we mapped the human genome. Now that's just jaw-dropping progress. That's awesome progress, especially when you consider that all of that has happened in the lifetimes of many people that are currently on Medicare. We've truly lived through an era of medical miracles. There's just one small problem. We can't afford it anymore. Now, to put that statement in perspective, I'd like to use a very simple graph. It's a qualitative graph. On the vertical axis, you see I've got outcomes. Imagine we had one number that told us how well we're doing in healthcare in terms of the outcomes we're able to produce. On the horizontal axis, I've got cost. That's per capita cost, how much we're spending on healthcare nationwide. Now, what I'm going to try and do on this graph is to show the frontiers of what's possible in healthcare and how that's shifted over time. I'm going to start way back in 1940. And as you can see, I've started pretty far low and to the left on the graph, which is to say there wasn't a whole lot that healthcare could do for us back then, but at least we didn't pay much for it. Now, of course, what innovation has done over the years is to push that frontier out. Let's start with the best case scenario. The best case scenario is something like a cheap and curative pill. Because the pill doesn't cost very much and it helps avoid downstream care, much more expensive care, this is the type of innovation that delivers a double win. It gives us both better outcomes and lower costs. A double win. Now, while it's nice to contemplate cheap and curative pills like penicillin, innovation as a whole has not been quite that good to us. And if you look at the way the trajectory has moved in aggregate, it has moved not upwards and to the left, but upwards and to the right, towards better outcomes, yes, but also towards higher costs. Now, as you can see, I've started several decades ago with a very steep trajectory. I think probably back then there was some recognition that we were paying more for healthcare, but nobody was too concerned about it because the improvements in terms of outcomes were astounding. But what's happened since then? Well, it's become very clear that the slope has gotten flatter. These days, we pay much, much more for every new medical innovation, and the benefits get smaller and smaller. Don't let that depress you, by the way, because that's normal. That's what happens in most every industry. Innovation trajectories tend to get flatter over time. One sign of the flattening of the curve is a very well documented increase in the frequency of medical reversals. That's when a new therapy comes out with good research to support it, but then not long after that, additional research comes out to show not so fast. If there are any physicians out there, I'll bet you can name at least one recently released new pharmaceutical that's only a little bit better than its predecessor and yet costs 5 times as much. We're on the flat part of the curve. We've got to add one more element to this graph to complete the picture, and that is the cost constraint that you see over to the right. We've simply come to the point where everybody recognizes that we cannot stay on this trajectory indefinitely. And that brings us to a very important question. Where do we go from here? What now? Well, listen, I do not want, nor do I imagine that you want, to stop pursuing the next breakthrough in the biosciences. So where now? Well, the answer is going to have to be innovation, but the very first thing we've got to recognize is that what got us here is not going to get us where we need to go. What we need is an entirely different kind of innovation. I'm going to call that innovation in healthcare delivery. Take a close look and you'll see that I've just made an astonishing promise on this graph. I've just said that innovations in healthcare delivery can be like penicillin. They can deliver the double wins, better outcomes and lower costs simultaneously. And I'll go further than that and say that there are opportunities for innovations in healthcare delivery in every medical condition, in every health system, and in every corner of this country. Now that may sound too good to be true, but it truly isn't, because these opportunities have been overlooked quite literally for decades, and for very understandable reasons. One of those reasons is our obsession with advances in the biosciences. And why wouldn't we be obsessed, given where we've come from and where we are today? But the other big reason is fee-for-service medicine. The sad fact about innovations in healthcare delivery is that by and large, they are money losers for the health systems that make them happen. And that's just crazy. Imagine that. We have a system that penalizes health systems for bringing forward innovations that constitute double wins, like penicillin. And that is why the biggest reason for optimism about the state of healthcare in the United States today is the steady and even accelerating progress that we are making in payment reform. There can be no going back. So what do these innovations in healthcare delivery look like? In this example, we'll take us out to Salt Lake City, Utah, and a primary children's hospital in particular. Innovations in healthcare delivery tend to focus on a patient population with a particular set of needs. We're going to talk about a special set of patients, children with complex medical conditions. Now, this can actually be a variety of medical conditions. It could be a brain injury or a spine injury. It could be a genetic defect. For many of these children, it's life support full-time in the form of a ventilator. So these are obviously children with challenging lives and families with challenging lives. These are children with complicated and, yes, expensive healthcare needs. Think about life for the parents of these children with me for just a second. Now, I confess that my wife and I feel like we've had a pretty successful morning if we simply get the kids out the door and off to school on time and with lunches in hand. Families like these have much more to think about. By and large, they want to take really great care of their children, but they're overwhelmed. There's so much to do. And there may be many different healthcare providers involved, and there may be conflicting advice depending on which one you're listening to. As a result, for these children, it's quite common to end up in the emergency room or in the hospital, and it's quite commonly the case that those outcomes were avoidable. The physician that you see on the screen right now is a Dr. Nancy Murphy, who started to become frustrated with the way the system falls short for these patients as early on as her residency. And when she had a chance to do something about it, she jumped on it. And that chance came in the form of the opportunity to create a small, full-time team that focused on these patients and these patients only. The team consisted of herself, a nurse care manager, a nurse practitioner, and a medical assistant. And because they were assigned to this project full-time, they had an enormous amount of flexibility. They could literally rethink from scratch what each of them did at work each day. Rethink when and how they saw patients, rethink when and what they did when they collaborated with each other. I can at least give you a thumbnail sketch of what they came up with. First of all, every time a family came into this clinic, they came in for a long appointment, typically 60 or even 90 minutes. And during that appointment, they would see not just Nancy Murphy herself, but typically all 4 members of her team, plus a specialist or 2 or a pediatrician or 2 that may also have been involved in that patient's care. There might have been up to 4 cases in the clinic at any one time, so you can imagine all these providers passing each other in the hall as they make the rounds and visit each of those families. Towards the end of the appointment block, either an hour or an hour and a half long, what would happen is that all the providers would come together for a huddle. And they'd quickly go around and share insights and observations about each case and make their recommendations about next steps. Once that meeting broke up, they would all return and make one last visit with the families to discuss those next steps. Now, as you can imagine, these families are dealing with a lot. They're frequently overwhelmed, as I mentioned before. There's so much to think about. They're dealing with trauma. They're dealing with a lot of emotion. So it's very often the case that as soon as they set foot into the parking lot, they remember a question that they meant to ask, or they have another question the next day or the next week. To address all those questions, this clinic sets aside 1/3 of its schedule just for ongoing communication with these families. A lot of questions come in by email, but they have to be answered by phone. And during this 1/3 of the schedule that's left open, there's also time to continue collaborating with the pediatricians or specialists that may also be involved in their care. That's the way this clinic works. I want you to notice that there's no biotechnology here. There's no cutting-edge science. What we're talking about is more care planning, more care coordination, and more close contact with families. That may not sound breakthrough, but the results are certainly breakthrough. The results, in fact, are a double win: better outcomes and lower costs. Better outcomes in the form of fewer emergency room visits, fewer hospitalizations, much higher patient satisfaction, and lower costs by at least 10%, and probably it now looks like closer to 20% of the total cost of care for taking care of these patients. Quite a phenomenal story, really. What would happen if we evaluated innovations in healthcare delivery not on the basis of pizzazz, not on the basis of science and technology, but on the basis of the results? Why wouldn't we celebrate any innovation that can deliver a double win just as we celebrate a breakthrough new device or a breakthrough new drug? But in fact, we don't do that. And that's one of the reasons why we have a giant field full of enormous watermelons. Part 3 is the prescription for fixing healthcare. And guess what? It's very simple. You take that one story and multiply it literally by tens of thousands of similar efforts. Now, I don't mean so similar that we're always talking about children with complex medical conditions. Let me share exactly what I mean, because all of the innovations we need share the following attributes in common. Number one, they take the form of a small, full-time team. That team is commissioned for a single initiative. I want you to notice that Nancy Murphy is not the chief of innovation. Okay? She is the head of a clinic. Her team was commissioned for a single innovation project. Next, the purpose of those teams is to redesign care from scratch and deliver better care. We're not talking about think tanks here. We're talking about teams that deliver care every single day, but do it in an entirely new format. All of this work is done with a particular and carefully selected patient population in mind. Small, full-time teams for single initiatives to redesign care from scratch and deliver that better care for a selected patient population. 10,000 of those, that's the prescription. Now let me observe, probably you've observed this already, that what I'm calling for here might be described as a grassroots approach, which is to say that the alternative might have been to say, let's stimulate, I don't know, a few dozen of these initiatives and then scale them up from local scale to national scale. But I think the grassroots approach is much more practical for each of these three reasons. Number one, healthcare is not one industry. It's a few dozen industries. There are a dozen different patient groups at least, okay, each with unique needs, and each innovation has to address a unique need. Number two, it's a very fragmented industry. There are not a small handful of national providers of healthcare services. There are thousands and thousands of hospitals scattered about the country. It's very hard to move these innovations across from one health system to another. Therefore, a grassroots approach makes more sense. But on top of all that, one way to think about, or one side effect of the research I've been doing has been to have a chance to closely study the differences, and there are many, between the way MDs think and MBAs. One such difference is this. If you show an MBA an innovation that works fantastically locally, the very next thought in that MBA's mind will be, how do we scale it up? How do we make it national? Heck, how do we make it global? There are some MDs that think that way, but by and large, MDs are much more attuned to the needs of the patients in front of them. Only a minority have an ambition to take their innovations and scale them up. At least that's been my experience. So I do think we need literally tens of thousands of similar style initiatives to what I've just described. Let's talk about the role for the physician leaders of these innovations. And I do pay particular attention to physician leaders because I think the odds are much higher when physicians engage in this kind of work, though there are certainly exceptions. There are nurse practitioners, physician assistants, physical therapists that are doing similar work. With that said, the job description, if you will, for physician innovators. Number one, choose a patient population. Number two, understand the needs of that population and understand it deeply. In my experience, the folks doing this work, this is where their passion lies, in a patient population that they care about deeply and deep knowledge of what those patients need to do or what services they need to achieve better health and better lives. Steps 3 and 4, this is really the fun part, to design and build a team from scratch, exactly as though you're building a new company from scratch. To choose the people, to choose the skills you need, to shape the job descriptions. And then literally, to figure out what everybody needs to be doing at work each day. Finally, prove it works. Measure outcomes, measure costs, show that you are in fact delivering double wins. I believe we need tens of thousands of physician innovators doing this kind of work. What's the attraction? Well, this isn't for every physician, that's for sure, but by and large, what's most appealing for the physicians doing this work, or what is very appealing, is an unparalleled level of autonomy. One of the things that comes with this work and can come with new value-based contracts is a lot less of administrators far, far away telling you what you can do, what you can't, what you will be paid for, what you won't be paid for, what you have to document in order to get paid, how, quote, productive you need to be. This is the stuff that's driving morale for physicians very, very low, and this can be an alternative path for some. An opportunity to build a team from scratch and define what it does at work each day, regardless of payment policies. With that kind of autonomy, of course, also comes accountability. You can have that autonomy if you can, in fact, demonstrate the double win, better outcomes and lower costs. I've focused so far on the innovation leaders that would head up a project like Murphy's full time. I want to shift our perspective now up one level or two levels in the organization and talk about what senior leaders need to do to make this kind of innovation happen in their own organizations. This part of the presentation is called The Climb to the Summit. It starts like the first one did with a very brief personal anecdote. Now, what we all share is an affinity for Hanover, New Hampshire and Dartmouth, and therefore what many of us share is an affinity for hiking. And that's certainly true of me, though most of you are probably far more serious about it than I am. I'm hardly ever gone for more than one day. That said, I've always had an aspiration somewhere in the back of my head that maybe someday I would take on a real mountaineering challenge. This is Mount Rainier out in Washington State, and I haven't climbed it yet, and it's quite possible I'll never get around to it. But I've talked to a few people that have, and I've learned something very interesting from those conversations. I've learned, in a nutshell, that there's a very big difference between a novice and an expert mountaineer. And that difference, quite simply, is that only the novice will celebrate at the summit. Think about that for a second. See, the expert understands that you never celebrate till you're safely back down to the bottom of the mountain. In fact, the expert understands beyond that that the real dangers are on the descent. Because as the day goes on, the sun gets higher, the temperatures rise, the snow gets softer and more vulnerable to collapse. And on top of all that, the climbers get more and more fatigued and more likely to make a big mistake. The expert understands that the real dangers are on the descent. Well, as it turns out, there is a Mount Rainier-like summit in every innovation journey, and it happens at that moment when you say, by gosh, that is a fantastic idea. Let's make it happen. Let's move forward. But of course, that breakthrough idea, that breakthrough inspiration is only a beginning. After the big idea comes what we sometimes call the other side of innovation. That's the journey from big idea to big impact. You know, across all industries, not just healthcare, but all industries, we do a lot better with innovation if we recognize from the get-go it's not one challenge, it's two. It's not just about the ideas, it's also about execution. And yet, there's like this magnetic force field that pulls everybody into, overwhelmingly, part one of the challenge, the idea part. That's where the glamour is. That's where the glitz is. And of course, an idea without execution isn't worth a thing. Execution challenge is perennially underestimated and underinvested in. Now, there are some exceptions to the rule, and since we're talking about healthcare today, it's really important to point out that biosciences-driven innovation is one of those exceptions. There, the ideas can be exceptionally complicated. I mean, you might need a PhD in molecular biology just to play a small role in the development of a new drug. That said, innovation in healthcare delivery is definitely not an exception to the rule. In fact, here the ideas are really easy, and in fact, we've been talking about them for decades. I'd go so far as to say that there may be just 4 big ideas in innovation in healthcare delivery, because almost every example I've come across falls into one of these 4 categories. Number 1, let's standardize care processes. Now look, this is one we've got to be very careful with, because you know and I know that patients are not widgets and hospitals are not manufacturing plants. But at the same time, there are double wins to be made out there that come simply from following the same principles that guided Henry Ford nearly a century ago. The second big idea is coordination of care. Those of you who are familiar with healthcare know that a lot can go wrong when care is poorly coordinated. Some care steps are repeated, some are missed altogether. Patients get confused, they feel overwhelmed, they disengage, outcomes are poor. The third big idea, prevention. Now, I'm not talking here about vitamins and exercise, things that apply to everybody in the population. I'm talking instead about something that's frequently being referred to these days as hotspotting. That is, identifying a high-risk set of patients, one that is very likely to have an acute episode in the near future, and then finding a creative way to intervene and to minimize that risk. The final big idea is improved medical decisions. And this is really very simple. When there is a consequential medical decision to be made and there is no crisis, slow down. Take the time to make sure all the options are on the table in front of both clinician and patient. Take the time to make sure that the benefits and risks and side effects of each one of those options is discussed. Provide the tools and the time needed for patients to reflect on what's important to them. Do all of that and then decide. Innovation in healthcare delivery boils down really to these 4 simple ideas applied in different ways to different patient populations. So crucial that senior executives resist the temptation to take the scarce innovation dollars they have and spend them on the search for new ideas. We don't need new ideas. We don't need high-tech ideas. We don't need big thinking and big solutions. All of that can help, but by gosh, look at what we can get done with simple ideas that have been around for a long time. Part 5 is bright and shiny new objects. Recognizing the need to invest not in ideas but execution is a good start, but still, innovation projects come in so many shapes and types and sizes. What I'll finish with is some additional guidance on the types of projects that must be invested in. You know, one of the challenges that plagues the field, the academic field of innovation, is that it's so hard to label the many different things that can be called innovation. There's all kinds of different efforts to categorize this type of innovation and that type. Maps of the terrain can be very helpful. And I'm going to suggest for our purposes today, we consider an extremely simple map. In fact, a one-dimensional map. What I've got here is a spectrum of innovation opportunities rated by their size. Their size, from very small ones on the left to very large ones on the right. I'm talking here about the magnitude of the resources required to execute. That's what I mean by size. So way over on the left, you might imagine any innovation project that one person could tackle on their own and in their free time. Maybe something as simple as a hospital employee going around the hospital to post more signs to remind clinicians to wash their hands. At the far right end of the spectrum, I want you to imagine something capital intensive. Maybe it's an effort to build a new chain of urgent care centers as an alternative to emergency room care. Now, let me point out that I have said nothing about the nature of the idea here. And indeed, anywhere on this spectrum, you can have a new idea or an old idea, a sustaining idea or a disruptive idea, an incremental idea or a radical idea, a high-tech idea or a low-tech idea. You get the idea. I've said nothing but size. Small projects on the left, big projects on the right. It is worthwhile for me to say that over on the left side of this spectrum, the label that tends to get used in practice is improvement, not innovation. On the right-hand side, the label that tends to get used is innovation. In practice, there's tons of overlap in how these labels are going to be used. And I'm not going to try and untangle that today. I view these as 2 ends of the spectrum of similar activities. I am going to say, however, that as you cross this spectrum, what you do is cross a phase shift in the physics of innovation. Phase shift, that's a term I pick very, very deliberately. I want you to think about H2O and the phase shifts that it goes through as it transforms from ice to water to steam. And think about just how dramatically the physical properties of H2O change each time. Similarly, as you cross this spectrum, there is a phase shift beyond which the physics of innovation, the activities involved and how you manage them, change dramatically. And as it turns out, the big pot of gold, which is to say the big area of untapped opportunity, lies just barely beyond that phase shift. Now, hopefully that's a pretty provocative statement, and you'd like me to say just a little bit more about what that phase shift is all about, and in fact, that's where I'm going next. I'm going to have to start with our one and only equation of the hour. It's a pretty straightforward one. All I'm trying to point out here is that the total resources in an organization can be divided into two categories: resources for ongoing operations and resources for innovation. Now, having said that, and by the way, I do think of this as the very first law of the physics of innovation, the physics of actually getting the work of innovation done. Having said that, I want us to focus in on one resource in particular, and that is the people in an organization and their time. I'd like to use this pie chart to get you thinking about this resource. I know it's rectangular, but trust me, it's like a pie chart. Notice that on the horizontal axis, I've got all the people in your organization from 0 to 100%, and on the vertical axis, I've got their time from 0 to 100%. Time is a crucial resource in any organization, and this resource, like any other, is going to get divided into those two pieces: ongoing operations and innovation. Why don't you think for just a moment about what portion of this pie you think ongoing operations consumes? So my guess is that most of you are imagining something like this. Okay? Yeah. Right? I do get pushback on this from time to time. It's always in one of two forms. Either, hey Chris, that blue square is too small, or, hey Chris, why does the vertical axis stop at only 100%? Right. And so that confronts us with a very real question. How are we going to make innovation happen? How are we going to squeeze it in? Everybody's already so busy. Well, let's look first at the most obvious option, one that's just calling out to us. Why don't we get everyone involved? Everyone's got at least a sliver of free time. Why don't we create a culture of innovation, one in which everybody feels inspired to come up with ideas and even perhaps to take some initiative to make things happen? This is, in fact, a very powerful approach to innovation, and I believe every organization should have a culture of innovation. And in fact, I've noticed that at recruiting time here at Tuck, every organization that comes here to recruit claims they have an incredibly powerful culture of innovation. And indeed, you can get a lot of work done here. And I wouldn't want to take a thing away from this type of egalitarian approach to innovation. But I do want to highlight that there is a physical limit to how far you can go with this approach, and it has everything to do with the size of an individual project. Think about it. Even if you're very, very persuasive and you take your sliver of slack time and you augment it with 3 or 4 or 5 friends who are all inspired by your idea and want to help you, you're still talking about a few slivers of slack time. That's not much. And indeed, any project larger than that, larger than a few slivers of slack time, is simply too large for a culture of innovation approach. So what's the alternative? Well, an alternative is not the horizontal stripe on the chart, but instead a vertical stripe on the chart, which is to say a small but full-time team that is focused on innovation, possibly even a single innovation project. Now, I want to point out that there are some big advantages to taking this approach. Let's start with the most obvious, and that is all of a sudden you can take on those larger projects, bigger than a few slivers of slack time. This is a little bit more subtle, but you also can work under the assumption that those resources are reliably available. See, one of the problems about working in that thin horizontal stripe at the top of the chart is that it frequently disappears. Ongoing operations get a little busier than normal, and all of a sudden, nobody has time for innovation. When you're working with the vertical stripe, you can count on those resources to be there and to be focused on innovation. But there's a third advantage, and this is certainly the most subtle of the three, but it is by far the most important and the most powerful of the three. When you work in that vertical stripe, you pick up an incredibly powerful new degree of freedom. All of a sudden, you are able to practice what I've referred to as clean slate team design, which is to say, you can rethink from scratch what everybody's role on the team is. You can rethink everybody's job. You can rethink how the team works together without any reference to what is normal or what already exists in the organization. And you can do that. You can have that freedom to rethink and redesign without breaking anything. And that's really important to notice. I very often get a little bit of pushback in this form. Why isn't this good enough? Which is to say, let's take a few people and carve out not all of their time, but let's say a third of their time or a quarter of their time. And I'm often asked, why isn't that good enough? Well, indeed, this approach will give you the first two advantages. You will be able to tackle larger projects, and these resources are somewhat more reliably available. But with only a couple of limited exceptions, you simply do not have the full flexibility that a full-time team gives you. Because if you radically reorganize what's going on in yellow, you'll almost certainly break what's going on in blue. You only get that full flexibility when you go to the full-time team. That is the most fundamental nature of the phase shift I referred to earlier. That increase in flexibility you get when you go from innovation executed part-time to innovation initiatives in which there are at least a small number of people involved full-time. All across the country in healthcare, what I'm seeing these days is health systems creating labs of some kind or innovation centers. And I want to caution that although this is a vertical stripe approach, this is also an approach that is focused typically on the climb to the summit, not the trip back down. So I very often get a response to that pie chart that sounds like we're already doing that. But if you dig a little deeper, you'll find that what is really being invested in is a think tank, okay? Not clinicians delivering services in a new way, and it's the latter that I'm focused on. Giving those teams flexibility is so crucial because, in my view, team redesign lies at the very core of innovation in healthcare delivery. You hear so much these days about team-based medicine, but I'm telling you that simply exhorting people to work as a team is not good enough. Step one is to build new and better teams from scratch. I'm very enthusiastic about the increase in investment in innovation I'm seeing by health systems across the country, but I'm simultaneously a little bit worried because the tendency appears to be to focus those innovations on the extremes of this spectrum that I've introduced, which is to say to invest way over on the left in continuous improvement efforts that are comfortable, where there's some history. Then what happens is very interesting. Maybe a few people get very, very excited and they have some money to spend on innovation, and one of their thoughts is, we've been doing continuous improvement. Now it's time to shoot for the moon. It's time to be breakthrough. It's time to be radical. It's time to be high tech. It's time to invest in the new cell phone app, the new wearable device, the new EMR system. You get the idea. It's time to go for a bright and shiny new object. And I have no doubt that there's some big value out there. But these projects are high risk, high reward. Wouldn't it be a shame if we jumped right past the more obvious opportunities in the middle, those that are based on simple, common sense principles that have been around for a long, long time? It's this middle of the spectrum that's been my focus today. There's a great deal of progress to be made there. There's a great deal of enormous watermelons just lying on the ground in the great big field of healthcare delivery. Let me summarize then 3 critical steps for senior leaders to take. Number 1, we've got to accelerate our transition to value-based payments. We've got to break away from fee-for-service medicine. This is the critical door opener that makes everything else I've been talking about today possible. Second, we've got to spend money sensibly on innovation in healthcare delivery, and that means investing in a whole lot of small, full-time clinical teams that redesign care and deliver better care for specific patient populations. And finally, we need to recruit those tens of thousands of physician innovators to do this kind of work. I've said a mouthful. I'm really intensely curious about your reactions, and I'd love to take a few questions from the audience in the time we have remaining. And Addie, I'll let you moderate.
Great. Thank you so much for submitting your questions.
the questions, Chris, so far have been in three general areas: about workforce, about costs and outcomes, and about healthcare consumers and retail health.
Okay.
So I'll start with the first, about workforce. I apologize if I mispronounce people's names. Rachel Gassana asked, how would redesigning healthcare innovation around small full-time teams affect or change the demand for healthcare professionals in the U.S.? Will we need more nurses, specialists, social workers, et cetera?
That's a really excellent question. It's a tough one to answer. What I can tell you is that the leaders doing this kind of work are taking a team approach, and part of what that means is finding ways to delegate as much as they can to all the various healthcare professions. So I think that what would likely happen is that we would see something of a decline in the demand for physicians and an increase in the demand for all other types of healthcare providers. Now, that's just a wild guess, and keep in mind that all of that would be offset by the expansion we're seeing in health insurance currently, and the expansion of the population. And so I really don't believe we're going to see a decline in demand anywhere in healthcare overall, but I do see the purpose of your question, and I do think that these innovations in and of themselves, though I think the need for physician leadership is high, their overall impact would be to shift work to other types of healthcare providers. I greatly appreciate the question.
Next, we have a set of questions about costs and outcomes. Matt Obenhaus asks that payment reforms, bundled payments could certainly constrain costs, but they could also incent hospitals to decrease quality, decrease innovation, consolidate, become local monopolies, and fail to pass on cost savings to consumers. Do you have any suggestions on preventing these forces?
You know, there are people here at Dartmouth that are far better positioned than I am to discuss the nuances of how new payment models are designed. Bundled payments is one option. And for those that aren't familiar, this is a single payment for a set of services all around a single episode. For example, in orthopedics, CMS is now pushing a single bundled payment for hip and knee replacements. And all of the arguments that you've made are potential risks to going in this direction. My top line anecdote is good measures and good metrics, but there's and if you have good measures and good metrics and leaders that want to do the right thing, I think we'll get the outcomes that we want, which is better outcomes at lower costs. But I'm not naive to the complications and the potential negative impacts of going in this direction. I'm just not the right person to discuss them in detail. What weighs so heavily on me is this giant field full of enormous watermelons. Innovations that have been encaged by fee-for-service despite the fact that they offer double wins, better outcomes, and lower costs. And might there be some unintended consequences of going in this direction? There might be, but the opportunity appears to be so rich to me, and in fact so much richer than continued investment in the biosciences, that I think that we'd be crazy not to do everything we can to move healthcare in that direction.
The next question comes from Michael Narkowitz. He says one of the major issues in innovation is that outcomes are set a priori by the payers. He gives the example that outcomes in Medicare don't always have a direct impact on patient-important outcomes, but might be focused on process measures instead. So how do we move the outcome discussion to locally defined and meaningful outcomes for those patients that are being helped with the innovation?
Yeah, I think that's a great observation. I think that we need a lot of innovation and experimentation in the types of contracts that we set and the types of metrics that are embedded in those contracts, just as we need innovations that I've been talking about today in the type of care that is delivered, the way it's delivered, and the people who are delivering it, and how they're working together and how they're working with patients. I don't have good answers there for how to pick just the right metric, and it's a tough question to answer because it's certainly different by patient population, but I share the same concerns that I think I'm hearing from you about picking one metric from a central location in Washington and assuming that it'll work in too many different healthcare contexts. I think it's a great question. I hope that this lunchtime webinar series will soon include some of my colleagues from the Dartmouth Institute that are experts on the very questions that you're asking.
A question from Patrick Burke. He says in the recurring dedicated team creation pie chart,
yes,
the slack time is taken up by the ongoing organization. However, in practice, how do you see resources for dedicated innovation teams being created in practice?
Well, Patrick, first of all, it's great to hear from you again. Patrick's a graduate of our Master's in Healthcare Delivery Science program, and I'm glad that you're engaged enough to keep connecting with us here at Dartmouth. It's great to hear from you again. I think you ask a great question, and I'd observe that it does take a leap of faith, or at least a leap into the unfamiliar, to commission a small team for a single innovation initiative focused on a single set of patients. But senior executives, and certainly senior executives in larger health systems around the country, have the resources at their disposal to take this on. Some of them are already doing it, supported by grants or supported by early value-based contracts that their organizations have already gotten into, and some of them have identified areas where even within fee-for-service doing this kind of work makes some sense. And there's lots of special sort of examples of where that's the case. But the key is pushing forward those value-based contracts, because once you do that, these type of investments make much more sense. All of a sudden, they don't look like big leaps of faith into the unknown, and they don't look like investments in care models that don't work under fee-for-service. What they look like is modest-sized risks with very high probabilities of return under the right payment model. How do you do it? You just do it. You make the choice. Maybe a way to get started is to help educate every physician leader in the organization as to the current state of payments within your organization and invite proposals. Tell me about what you'd do if you had a small full-time team dedicated to a particular patient population that you really care about. And if you think you can deliver the double win, we'll work with you to get the payment model that works, and we'll fund that innovation. It's new, but there's already a few hundred examples across the country, and I think that's a good start.
So transitioning to a new topic, we've had a number of questions coming in about healthcare consumerism and retail health. So Stephen Lin was curious, how can consumer-driven healthcare, and by that he means efforts to empower healthcare consumers to make knowledgeable decisions about their spending. So how can consumer-driven healthcare help to achieve these double wins, or this pill that you prescribe? Yeah. It seems that you're suggesting the small team approach would drive healthcare decision-making.
Yeah, look, I am putting a bright light, or my intent is to put a bright light on a class of innovation initiatives that has been overlooked quite literally for decades, for the reasons that I described earlier. Though I am putting my emphasis on that class of innovation initiatives, I certainly don't mean to exclude other possibilities, and there are lots of avenues to better outcomes and lowered costs. And I think some of the consumer-directed health initiatives that are in progress out there, many of which simply focus on price transparency and encouraging consumers of healthcare services to be more aware of the value of what they're buying, are positive moves. They are taking us in the right direction. I have some personal concerns about just how far you can go with that, just how good a shopper one can be about a service that you may need once in your life and is very high-tech and very scientific in nature. But I think that there's a lot of runway there, and there's a lot of positive work that can be done there. I wouldn't take anything away from that stream of work at all. If I hope to accomplish one thing, it's simply to shine a light on innovation opportunities that are being overlooked. Okay.
Another question in that same vein, Jonathan Sullivan asks about the trend in retail care. Does this square with what you're proposing? Standardization seems applicable in the retail care setting, but some of the other principles might go against the core of what retail medicine is really about.
I think retail medicine has a role. I think that to the extent it increases the accessibility of healthcare and helps head off problems that could grow much worse and become much more expensive, it's certainly a positive. I think to the extent that we're substituting lower quality services where higher quality services are needed, we need to be careful. I think that retail healthcare in conjunction with partnerships with health systems might be more promising, but also certainly more complicated. We'll see where that goes down the road, but I think there's a lot of positives that can come out of that movement towards retail care. And I think that what's particularly interesting to me is a set of innovation initiatives that I didn't talk about today that sort of, I'm inspired to mention them by the last two questions. They're focused on consumer engagement. They're focused on consumer activation, if you will, but they're more focused on health behaviors. And while the Fitbit or the cell phone app can help, a lot of clinicians believe that it's going to take ongoing human engagement to inspire the kind of behavior change that will help us overcome, for example, the diabetes epidemic. And so I'm equally interested in care models within health systems that deliver proactive and high-intensity primary care to those who would most benefit from it. That's a whole another sort of subclass of innovation initiatives among the bigger set that I've described today. And Addie, glancing at the clock, I'm thinking perhaps one more question.
Yes, thank you. Daryl Story made a comment, and I thought you might like to respond.
Yeah.
He or she says, many doctors would like to be in the innovation stripe, but not fully give up their clinical activity and losing those clinical skills. What do you suggest?
Well, I'd point out, Daryl, that in every one of the cases I've looked at, physicians that are leading these initiatives remain clinicians. It's part of their work. Certainly the balance of how they spend their time changes. They do have a new job. It is more focused in terms of the patients they see than what they experienced in the past. So you're seeing a narrower subset of patients, but you are seeing patients. You're still spending probably half your time doing that. You're probably spending a lot more time managing and leading, however, than you were in the past. Building a team and leading a team is a lot of hard work. I don't suggest that this career transition is for everyone. Let's keep in mind that there's 1 million physicians in the country. I'm looking for tens of thousands to take on this kind of work. That's a few percent. It's a big opportunity for the right kinds of physicians that, as I say, have a particular passion for a particular patient population, have a team orientation, are attracted overall to the idea of building a different kind of team that can outperform the system we have today. Those were a great set of questions, and I thank you for your participation, for your attendance. Just a couple of words of wrap-up before we go. I focused today on the need for small full-time teams. But you know, these teams never work in isolation. They typically work in partnership with others inside a large organization, and I've labeled that group the shared staff here. I bring this up because the partnership I've pictured here between a dedicated team and a shared staff is inevitably a tricky one to manage. And in fact, figuring out how to manage such a partnership has been a preoccupation of mine for the entire time I've been here at Tuck and across all the industries I've looked at over those years. And managing that kind of team structure is one of the big pieces of the book, How Physicians Can Fix Healthcare, One Innovation at a Time, that I published last fall. It'll take you several steps beyond what I was able to share with you today. Another book that is similar in topic but very different in style is called How Stella Saved the Farm, a simple story about innovation. It's about a farm in trouble and how it innovates to get out of trouble. And in the tradition of George Orwell, it is the animals that run the farm. The great thing about this book is that almost everyone that starts reading it will finish reading it, and then they'll want to talk about it. It is a great tool to use to instigate a productive conversation about innovation in your own organization. I'll mention one last resource, and that is a website called The Physician Innovator. It's still new. You might even say it's still in beta, but it is my current work to build it into a platform for ongoing learning about innovation in healthcare delivery, with the hopes that a physician innovator in Utah, like Nancy Murphy, might inspire one in a completely different part of the country to do something quite similar. Thank you for your time today and for joining me for this hour. I'll remind you that in just 2 weeks we'll have our next installment in this free lunchtime Dartmouth and Tuck webinar series. The next speaker will be my colleague Paul Argenti, and the topic will be telling your career story, the power of narrative. Sounds to me like one you don't want to miss. Cheers.